Welcome to this Step 2 clinical knowledge review on labor and delivery test-taking strategies. This video is brought to you by Roadmap to Residency. We are going to break down the most common question patterns you will see on your board exam for labor and delivery topics and teach you strategies to pick the right answer quickly and confidently. The goal here is not to reteach the entire topic, but to help you recognize the patterns and apply test-taking strategies when you are under time pressure. Make sure you have reviewed the obstetrics and gynecology sections of first aid and your question bank before or alongside this video. Let us jump right in. Here is what we are going to cover today. First, we will learn to recognize the high-yield question, stems for labor and delivery that come up again and again on Step 2. Second, we will go through test-taking strategies for the 4 biggest topics: stages of labor, fetal heart rate monitoring, labor augmentation, and cesarean section indications. Third, we will master the next best step question format, which is how most labor and delivery questions are actually asked on the exam. Before watching this, you should have already reviewed the obstetrics chapters in first aid and worked through related questions in your question bank. This video is about applying that knowledge under test conditions, not learning it from scratch. Our first strategy is what I call the stages of labor framework. When you see a labor question on boards, the very first thing you need to figure out is what stage of labor the patient is in, because the management is completely different depending on the stage. For the latent phase, look for regular contractions with slow cervical change from 0 to 6 centimeters. The keyboard pearl here is that latent labor does not have a strict time limit, and the most common wrong answer is premature intervention. If they describe a patient in latent labor, the answer is almost always expectant management or therapeutic rest, not augmentation or cesarean delivery. For the active phase, you are looking for cervical dilation beyond 6 centimeters. Active labor arrest is defined as no cervical change for 4 or more hours with adequate contractions, or 6 or more hours without adequate contractions. Memorize those time cutoffs because they are tested directly. Strategy 2 is about decoding fetal heart rate tracings, which is one of the most heavily tested topics in all of obstetrics on Step 2. The board examiners will describe a tracing and expect you to categorize it and choose the correct next step. For reassuring tracings, or Category 1, you are looking for a baseline between 110 and 160 beats per minute, moderate variability, the presence of accelerations, and no late or variable decelerations. When you see all of these features described, the answer is always to continue current management, no intervention needed. For non-reassuring tracings, or Category 3, look for absent variability combined with recurrent late decelerations, recurrent variable decelerations, or frank bradycardia. When the STEM describes these features, the answer is almost always immediate delivery, usually by emergent cesarean. Category 2 is the tricky middle ground, and typically the answer involves intrauterine resuscitation measures like repositioning the mother, giving intravenous fluids, administering oxygen, or stopping oxytocin. Now let us talk about recognizing high-yield question stems. For labor augmentation, the classic stem describes a patient in active labor whose cervical dilation has stalled. The contractions are irregular or spaced too far apart. The question will often mention whether membranes are intact or ruptured because that determines whether you do an amniotomy first or go straight to oxytocin. For cesarean section indications, you will see stems describing active phase arrest despite adequate contractions, a non-reassuring Category 3 fetal heart rate tracing, or malpresentation like a transverse lie. You need to know the difference between absolute indications like complete placenta previa and relative indications. For second stage arrest, the STEM will describe a fully dilated patient who has been pushing for an extended period without fetal descent. Pay close attention to whether the patient has an epidural because that changes the time limits. With an epidural, you allow longer pushing before calling it an arrest. Here is our first practice question. Read through this STEM carefully. We have a 26-year-old first-time mother at 39 weeks who has been in active labor at 6 centimeters for 4 hours. She has adequate contractions confirmed by an intrauterine pressure catheter showing greater than 200 Montevideo units, but her cervix has not changed. The fetal heart rate tracing is reassuring. Take a moment to think about what you would choose before we go through the answer together. Let us walk through this answer step by step. Step 1. Spot the pattern. We have a nulliparous woman in active labor at 6 centimeters with no cervical change for 4 hours, and the intrauterine pressure catheter confirms adequate contractions at greater than 200 Montevideo units. This is the classic active phase arrest pattern. Step 2. Apply the rule. The board rule is that active phase arrest is defined as no cervical change for 4 or more hours when contractions are adequate. Since contractions are already adequate and the cervix is not changing, augmentation is not going to help. With a reassuring fetal tracing, this meets the criteria for cesarean delivery. Step 3. Eliminate the wrong answers. Choice A, continuing to wait, is wrong because we have already met the time criteria. Choice B, giving oxytocin, is wrong because contractions are already adequate. Choice D, amniotomy, would be reasonable if contractions were inadequate, but they are already sufficient. The answer is C, cesarean delivery. Here is our second practice question. We have a 32-year-old woman at 38 weeks in active labor at 8 centimeters. The fetal heart rate tracing shows a baseline of 150, but there is absent variability with recurrent late decelerations for 30 minutes. They have already tried intrauterine resuscitation with repositioning and fluids, but the tracing has not improved. Think about how you would categorize this tracing and what the next best step should be. Let us walk through this one. First, categorize the tracing. Absent variability combined with recurrent late decelerations is a Category 3 tracing. This is the most ominous fetal heart rate pattern, and it suggests significant fetal acidemia. The key information in the stem is that intrauterine resuscitation has already been tried and failed. Choice A, continuing to observe, is dangerous when you have a persistent Category 3 tracing. Choice B, terbutaline, is a tocolytic that helps with tachysystole, which is excessive uterine contractions, but the problem here is the tracing pattern, not contraction frequency. Choice D, applying a fetal scalp electrode, might give you better quality data, but it does not change the fact that the tracing is Category 3 and resuscitation has failed. The answer is C, emergent cesarean delivery. Remember, when the board question describes a Category 3 tracing that does not improve with resuscitation, the answer is almost always emergent operative delivery. Let us review some key augmentation and induction facts for the boards. Oxytocin is the first-line agent for augmenting labor when contractions are inadequate. It is titrated upward until you get adequate contractions, usually measured as greater than 200 Montevideo units on an intrauterine pressure catheter. The boards love to test that amniotomy should be performed before or alongside starting oxytocin when the membranes are still intact. For cervical ripening and induction, misoprostol and mechanical methods like a cervical balloon are used when the cervix is unfavorable, meaning the Bishop score is low. The absolute highest yield pearl here is that misoprostol is contraindicated in patients with a prior cesarean delivery or any uterine scar. This is because misoprostol can cause uterine tachysystole, which dramatically increases the risk of uterine rupture at the scar site. This shows up as a wrong answer trap on nearly every practice exam. Here is our third practice question, and this one tests cesarean section indications. We have a 34-year-old woman at 40 weeks who had a prior low transverse cesarean delivery 2 years ago. She wants a trial of labor after cesarean. She is at 5 centimeters with regular contractions, but the cervix has not changed in 6 hours despite adequate contractions. The fetal tracing is reassuring. Think about what the best next step is, keeping in mind her surgical history. Let us break this down. The key facts are prior low transverse cesarean, labor at 5 centimeters that has not progressed for 6 hours despite adequate contractions, and a reassuring fetal tracing. This is active phase arrest in the setting of a trial of labor after cesarean. Choice A, continuing to wait, is dangerous because the labor has already arrested and prolonged labor in a scarred uterus increases the risk of uterine rupture. Choice B, augmenting with oxytocin, is relatively contraindicated because the contractions are already adequate and the labor has arrested. Pushing harder with oxytocin in a patient with a uterine scar raises the rupture risk substantially. Choice D, misoprostol, is absolutely contraindicated in any patient with a prior uterine scar. That is a classic board trap, and if you see misoprostol offered alongside a history of cesarean delivery, you can eliminate it immediately. The answer is C, repeat cesarean delivery. The low threshold for converting from trial of labor to cesarean delivery when arrest occurs is a critical board concept. Here is your rapid review test-taking pearl for cesarean indications. The absolute indications you must memorize are complete placenta previa, vasa previa, active genital herpes outbreak at the time of labor, transverse lie, prior classical or T-shaped uterine incision, and failed operative vaginal delivery attempt. If the question stem includes any of these, choose cesarean delivery regardless of what other information they give you. For your overall board strategy on labor and delivery questions, use this three-step approach every time. First, categorize the fetal heart rate tracing. Second, determine the stage of labor the patient is in. Third, check for any contraindications to vaginal delivery. This framework will get you to the right answer on the vast majority of labor and delivery questions. Practice it over and over in your question bank until it becomes automatic. That wraps up our labor and delivery test-taking strategies for Step 2. To solidify this material, go back and review the obstetrics chapters in First Aid, especially the sections on labor management, fetal heart rate monitoring, and operative delivery. Then hit your question bank hard and practice applying the three-step framework we discussed. Categorize the tracing, determine the stage of labor, and check for contraindications. Visit roadmaptoresidency.com for expert tutors and residency advisors who can help you with one-on-one board preparation and match strategy. If this video helped you, please like and subscribe so we can keep making content like this. Good luck on your exam, and we will see you in the next video.